Okay, good evening, everyone, and welcome. I'm Claire. I'm editor of Medical Chronicle. I'm joined here by Trish Idenson and Liesel Nordier, who will be presenting on Save Our Skin with Leukoplast Skin Sensitive. This webinar has been made possible by Leukoplast. Since their successful Leukoplast Skin Sensitive launch last year, they have received an overwhelming response and are excited to continue the journey of saving our skin from skin tears with our experts Trish Idenson and Liesel Nordier. Trish Idenson is going to present first. She is a registered nurse and midwife. She has an MSc in clinical skin integrity and wound management and also has completed an international interdisciplinary wound care course in Toronto. She is a wound nurse specialist, owner of Clinicare Medical Center, and provides wound management in the clinical, hospital, subacute, and home environments. She is principal lecturer and coordinator of the postgraduate wound certification course for the University of the Free State. She is on the editorial board for Wound Masterclass, a committee member of the International Surgical Wound Complications Advisory Panel, past board member of the International Skin Tear Advisory Panel, and a current committee member of the International Wound Infection Institute. Liesel will present next. She has been at the forefront of wound management in South Africa since the inauguration of the Wound Healing Association of Southern Africa, WASA, in 2005, where she was part of the conference organizing committee. Since 2005, she has played a key role within WASA in establishing the organization of the official journal of Wound Healing Southern Africa. She is a past president of WASA and has been a member of the executive committee from 2005 till 2013. She is a member of the advisory panel for the World Alliance of Wound and Lymphedema Care since 2009 and EXCO member for the Pan-African Diabetic Foot Study Group since 2013. She was awarded honorary life membership by WASA in 2011 at the Wounds International Conference for her contribution towards wound care in South Africa. She also received recognition as an international nurse leader in 2013 from the International Nurses Association. In 2017, she won Best E-Poster Award for her work on intermittent vacuum therapy at EWMA. Liesel has presented several topics at national and international conferences and authors several publications in both national and international journals. She also pioneered the South African Total Contact Cast system in collaboration with BSN Medical. Here is some guidance for the webinar. If you have a bad connection, there's a box at the top of your screen that says Reconnect. Please click this button if you have any issues. It will bring you right back into the webinar. There will be a recording of this webinar available to watch. You'll receive the link via email after the webinar later tonight. Tonight is something different. It's a product information webinar and not for CPD points. It's not about competitor products or price, so please note we won't be addressing this. For details on price, kindly contact your sales representative. I will put these details in the chat section. There are also some prizes up for grabs, so please pay attention to the presentations as the presenters will ask a question at the end of each of their sessions. The first person to answer correctly in the Q&A box will win the prize. Please note that's the Q&A box only, not the chat box. You must put your answers in there. There will also be a bonus prize for the most interesting or best question asked by the audience tonight. Prize winners will be announced after the webinar. I'm now going to hand over to Trish. Please note that both speakers have asked me to address them by their first names only and not by their qualifications, so we are all on a first name basis tonight. While I get her presentation ready, please type Y for yes in the chat section if you consent to being added to our sponsors attendance register for tonight. This won't affect anything, so just Y for yes if you would like to be added to Leukoplast attendance register. Okay, here we go.
Good evening, everyone, and welcome. I see lots of familiar names in the chat group. It's great to have you here this evening with us, especially the night before public holiday. So, Save Our Skin, another form of SOS from skin tears. I disclose I am a consultant for Essity and consent has been obtained from all individuals to present their photos to you according to the South African Poppy Act 2013. Our skin is a vital organ, as you all know, with many varied functions, and we know that every millimeter of skin really does count. And tonight is such an appropriate evening to have this webinar, as ISTAP, the International Skin Advisory Panel, has recognized the importance of preventing skin tears, and in 2 days' time, on the 28th of April, hosts the global A World Without Skin Tears Day 2022. Now, just imagine what the world would be like with no skin tears. That would be amazing. So that would be our goal and objective, because people who have had skin tears actually report these wounds to be really painful, that they negatively affect the individual's quality of life, they cause distress, and increase the likelihood of hospitalization. And if an individual suffers a skin tear within hospital, this may prolong hospitalization time. But let's start right at the beginning with what is a skin tear. In the year 2018, skin tear was defined by ISTAP. It is one of 13 definitions that do exist, but it is the latest one. And a skin tear is a traumatic wound caused by mechanical forces, including removal of medical adhesives. Severity may vary by depth, not extending through the subcutaneous layer. Take note of the subcutaneous layer. The clinically validated and reliable skin tear classification tool facilitates systematic assessment and reporting of skin tears in clinical practice, audit, and research. It differentiates between 3 types of skin tears by skin loss. Type 1, having no skin loss. The flap can be repositioned to cover the wound bed. Type 2, partial flap loss, which cannot be repositioned to cover the wound bed. And type 3, total flap loss, exposing the entire wound bed. The flap in skin tears is defined as a portion of the skin, be it the epidermis or the dermis and the dermis, that is unintentionally separated, partially or fully, from its original place due to shear, friction, and or blunt force. This concept is not to be confused with tissue that is intentionally detached from its place of origin for therapeutic use, for example, surgical skin grafting. So there is no ICD-10 or ICD-11 code, which is relevant in other countries, of the morbidity and mortality code for a skin tear. So the most appropriate would be laceration, as per the body part. As you can see here, there are all the different body parts in the ICD-10 coding. It's classified under the injury section, and the injury has been defined as an injury which means physical harm resulting from interaction of the body with energy, that's mechanical forces, in an amount that exceeds physical tolerance. Now, this is a problem because with the lack of coding, it contributes to skin tears being perceived as insignificant injuries and therefore being poorly understood, poorly reported, and unfortunately, poorly managed. And when skin tears are poorly managed, mismanagement and misdiagnosis leads to complications like pain, infection, delayed wound healing, and increased costs to the healthcare system, let alone the increase to indirect costs too, out of work, psychological stress, etc. Finance. So do you recognize the mismanagement of this individual skin tear on the arm? The practitioner has utilized adhesive strips, which have high adhesion to this frail skin and not recommended by international best practice. As on removal, more skin tearing can occur. They also have been placed onto the skin with tension, and you can see, because this is a traumatic wound, there's edema, and this leads to further tearing and even blistering. So are skin tears actually a problem? Why are we worried about them? Well, if you have a look at the prevalence of skin tears in long-term care, now you're going to go, yes, we know that, Trish, it's mostly in the aged. Well, it is prevalent, 3 to 22%. But if you have a look at the community, which is a frightening prevalence, just below 20% of all wounds in all age groups in the communities are skin tears. Now, that's quite a frightening statistic. Most of skin tears occur on the upper extremities, so 50 to 80% of them you'll find on the arm, the forearm, the hand. So we mentioned that the causes are mechanical forces, and the mechanical forces we are speaking about are shear, frictional force, and blunt trauma. Here you can see this gentleman with a laceration to his forehead. Ironically, he had a wound that was infected on his foot, and he became delirious from the systemic infection, and he fell. So this would be caused by blunt trauma. On the other hand, healthcare practitioners with poor handling technique or circle of care, or spouses for that matter, can cause friction or shear forces. And equipment injury. Now, how many of us on night duty have arrived to the bedside and seen the patient with their legs dangling through those bed rails, either grasping for a glass of water or maybe just getting nocturnal ischemia? And that can cause injury too. But let's not forget, right down to the foot flaps of the wheelchairs. Those can also cause many skin tears, as you can see on this ischemic leg, the ischemic foot, where we've only just managed to close an arterial ulcer and now have multiple skin tears to deal with. And the removal of that adherent dressing, poor selection of dressing for frail skin. And this was taken in the community by a husband who was so proud of himself that he had managed to stop the bleeding at the top of the wound, sister, with this very sticky fabric. Well, my nightmare was, how are we going to take this off atraumatically? It's extremely difficult not to cause a tear in this situation. On the other hand, this is an iatrogenic skin tear, and you can see on the anterior aspect of the upper leg, this patient has had surgery, and for this surgery, an incisional drape was applied. That is a high adhesive dressing. And on removal of this in the theatre, there were multiple skin tears caused, and this wasn't immediately. As you can see, the skin tear on the right is already adhering to the wound. But iatrogenic is severe. Obviously, it has litigation consequences. We must also be aware that patients who require assistance with activities of daily living, such as mobility, that's washing and dressing, putting their clothes on, are at increased risk of skin tears due to all the handling and the force and trauma. So gentle handling is really essential. How do we minimize the force, these forces? Well, you can see this ingenious device of the walker, padded by one of my daughter, the daughter of the patient, and she's used the swimming pool foam noodle to pad the walker. We can provide bed rail pads, and we really shouldn't be buying beds, hospital beds and institutions if there aren't any pads available. And in the home care situation, perhaps relatives could even make these. We suggest that you use an adhesive remover to take off dressings. In fact, I think it's essential for any wound manager to use adhesive removers. And please remember that they should be alcohol-free, otherwise they will burn. And using dressings with gentle adhesion. Now, one of the recommended dressings by ISNAP is silicone, and we're going to speak about that quite a lot this evening because silicone has a low surface tension that allows the dressing to make contact with the skin surface as it's applied, but it requires less adhesion to secure the dressing and therefore requires less peel force on removal. There are many intrinsic causes. This is one of an example of a silicone dressing that's been applied. There's many intrinsic risk factors as well. The one we're going to focus on this evening, and there's many more that apart from on the slide as well, is aging, because out of all the factors, this is the one that is really of utmost importance, and we see it so often in the aged, or in aging skin, or in frail skin. And here are some typical features of aging skin. The first is dyspigmentation, so it's good for us to be able to recognize this as the fragile, high risk of developing skin tears when we see this kind of skin. You can see the stellate pseudoscars, and these result from repeated small injuries that do not heal completely, and the senile purpura, and this is from extravasation of bleeding into the dermal space. At this point, we will take a glimpse at the structure of the skin pertinent to skin tears and the effects of aging on the skin. So here you can see skin can be extremely sexy, and we speak with our skin too. We have frowns, we have smiles, we touch, we feel temperature, and it's a real complex architecture. And even under the microscope, it's extremely complex, as you can see. So it's composed of three main layers. The epidermis is the outer and the upper layer of the skin, and the dermis sits just below the epidermis. The epidermis and the dermis are in intimate contact. They're tightly interconnected at the dermo-epidermal junction, which you can see here by the ridges on the screen. Below the dermis is the subcutis. You may also know it as the hypodermis or the subcutaneous layer. Each layer houses different structures to perform unique functions. The epidermis provides a waterproof barrier to control the moisture into the body. You may be familiar with the TEWL, the transepidermal water loss regulation that we always refer to with incontinent-associated dermatitis, and this actually all occurs in the epidermis. Keratinocytes make up 95% of our cells present in the epidermis, and it's important to note that the epidermis is avascular. That means it's not perfused. So if you cut yourself with a piece of paper and you only cut into the epidermis, you'll find that there's no bleeding. You'll go, oh, it's absolutely fine. It's nothing at all. And I'm going to come back to one of those epidermal skin tears. The epidermis plays a minor role when we discuss the mechanical properties of skin, but it is important to highlight the dermis in this regard, that accounts for approximately 90% of the weight of the skin and forms the foundation of this organ system. I call it the goodie box, as this connective tissue consists of lots of goodies, mainly of extracellular matrix, apart from water, vascular endothelial cells and fibroblasts, along with adipose glands, your sweat glands, hair follicles, nerve endings, and blood vessels. And that's really important because therefore we know that the dermis is perfused. The stratum papillare is the uppermost layer of the dermis and consists of an open network of fine fibers, forming a loose structure which allows deformation and movement of this area. The stratum reticulare lies below the papillare and consists of an abundance of fibroblasts that synthesize a large part of the extracellular matrix. They form a dense fibrous network and are made up mostly of collagen and smaller amount of elastin. And these provide the mechanical tensile strength and elasticity of the skin. There's a ground substance resembling a gel-like semi-fluid that fills in the spaces of the network and allows for molecular viscous sliding, which is extremely important when it comes to the mechanical forces of shear and friction. The subcutis is the deepest layer of the skin that connects the dermis to the muscle and the bone. So by now, I'm sure you can see those typical features I spoke about earlier on this skin frail person. So let's talk about the changes that occur, or I'm just going to mention the changes because there's so many. There's the thinning of dermis, the flat dermal junction, loss of collagen, elastin, and glycosaminoglycans. The common name for this is GAGs, G-A-G-S. And the most common ones are hyaluronic acid and dermatan sulfate that we find in products on the shelf for aging skin. Atrophy and contractility of the sweat and sebaceous glands, and that's why we get dryness in aged skin. Thinning of the blood vessels of the blood supply to the extremities where we really need them with skin tears because most of them are occurring on the upper extremities. And increased low echogenic pixels and solar elastosis. This actually indicates that skin tear risk factors might not only represent chronological aging, but also photoaging. So it's no wonder aging skin is at a high risk of skin tears. I'd like to introduce you to a term this evening called skin frailty. And this term was actually defined in 2020 by ISTAT, and it implies at-risk, vulnerable skin, not necessarily a wound, a break, or a disruption in the skin. Both immature, and I speak about neonatal skin at this stage when I speak about immature, and aging skin are both at risk and vulnerable of skin frailty. So you can see these poor little neonates with their fragile skin, remembering that their skin is not fully matured and it remains high risk up to 3 years of age. So extra care is really needed to ensure that all products used on neonatal skin are compatible with highly permeable newborn and infant skin. Further research is required in neonates, and there's actually a lot of research that's going on right now that I know of colleagues, but has not been published, so watch this space. So this evening, the focus is on skin tears in the aging skin. And first and foremost, we should always be doing a skin tear risk assessment on all of our patients when they come to the wound clinic. They're admitted for hospital, for surgery, and long-term facilities. It should be done on admission. At the first visit, ongoing and identified at-risk already patients, and on condition change. We find that if any patient has any identified risk factors, we should implement a risk reduction program checklist. Now, the risk assessment and the risk reduction program checklist follows 3 main concepts, and that is the skin and mobility and general health. This forms a checklist that you can download. It's free from the ISTAT website. And you literally just check it off at admission. You can put it on your own documentation. It's really easy. I'm not going to go through each one of these, but I'm going to change to a very practical pictorial few slides now to go through them. But first of all, I just want to stress systematic reviews, you all know, is one of the highest forms of evidence. And this was a very recent one in 2019, which is done by Leukoplast. And the conclusions here were basic skin care strategies, including low irritating cleansers and humectant-contained leave-on products, are helpful for treating dry skin and improve the skin barrier in the aged. Now, if you're wondering, gosh, I've forgotten what a humectant is. For example, urea-containing product, it supports the skin hydration because it draws water from the dermis to the epidermis and compensates for the reduced levels of the natural moisturizers in the skin. These leave-on products as well with low pH have a positive effect on improving the skin, and I'm going to elaborate on that now, as well as the regular use of leave-on products which prevent skin tear development. Now, do you have any idea what that leave-on product is that would prevent skin tear development? And what's published time and time again, that regular moisturizing is an essential everyday skincare routine in individuals to promote skin health and skin injury prevention. If applied twice a day, it'll reduce the incidence of skin tears by 50%, so by half, just by applying twice a day. Moisturizing reduces itching and increases the level of hydration. Now, who wouldn't want to moisturize? I'd like to bring your attention to skin tears and in different skin tones. So the best practice statement addressing skin tone bias in wound care, published last year in Wounds UK 2021, made mention that dark skin tones are more likely to experience skin irritation and dry skin, and recommend the introduction of a moisturizing regimen very early on to prevent damage as well as reoccurrence. You can actually see the dryness on the palm of this individual's hand. Skincare, bathing, bathing, if you want to, we all know it as, this needs to be minimized, in fact, almost avoided in frail skin. We should be rather using wipes. It's a lot more gentle, but if people really need to have to bath, then rather just use lukewarm water. Pat dry with a soft towel. Don't rub that frail skin. And always be aware and manage incontinence appropriately, and always observe the skin carefully. So here's a few pictorial slides. I thought you may be tired of reading. And what I want to point out here is to reduce the risk of skin tears caused by the removal of medical adhesives. Healthcare professionals, carers, and individuals are always advised to keep the fingernails trimmed and filed. And that's not to little points. Yesterday I had a patient with little pointed fingernails with this very frail skin and already 2 skin tears. So please make sure they are filed and no jewelry is worn when dealing with patients. We need to use medical adhesive removal wipes, sprays, and skin barriers I mentioned previously. And when removing dressings, it should always be removed slowly and horizontally to decrease the peel force and the skin damage. Also mentioned previously was the use of silicone tapes for fixation of dressings or devices. And why do we use these? Can you remember? Yep, it's to reduce that peel force and discomfort on removal. We want atraumatic removal, and there's less propensity for epidermal stripping. We need to also look at the polypharmacy. Lots of the aged have a lot of different medications that can interact with each other. We also need to have a look at corticosteroids, remembering that they increase susceptibility to infection. They also suppress fibroblasts and collagen, interfere with inflammatory, etc., etc. We need to be aware of when we cover skin with appropriate clothing or retention bandages. We need to do this carefully to protect the skin, and even use stockinette in vulnerable patients if those other protective barrier wear are too tight to get onto the skin. Mobility, we spoke about the padding of all those bed rails, etc. earlier, but please consider hoists, mattress handles, and glide sheets. So often we see the hoists in the storeroom and not being utilized. Protect your own backs too, never mind the skin tears. Good lighting, clear the clutter in the passages. Get those pets' claws clipped and trimmed so they don't cause skin tears. Avoid the obstacles, and we all know we are to wear sensible shoes. Make sure they have good balance and protection. We also don't want shoes causing skin tears on the patients. And with regards to general health, we need to look at optimal nutrition and hydration, review the medications that affect perception, sedatives, as well as I mentioned the polypharmacy. Refer patients if there's impaired sensory perception, like sight, auditory, and neuropathy, be it all or even one of sensory, autonomic, and motor neuropathy. I'd like to spend the next few minutes on the management of skin tears. And this is really easy when we follow the ISTAT decision algorithm. And as I mentioned, all of this is freely available on the ISTAT website, which I'll give you the address just now. So we're going to go through this. This is a lovely step-by-step to guide us. So the first thing is to control bleeding. And we need to teach carers especially how to apply pressure if this occurs, because just by applying pressure, we can actually increase the shear and the frictional forces and cause more skin damage. Elevate the limb if it's appropriate, if the skin tear is on a limb, and selected dressing to assist with hemostasis. This could be a cyanoacrylate, fibrin dressing, alginate, even a cellulose or a collagen dressing to help control the bleeding. So we need to assess that wound. We need to assess the patient, and we need to assess the environment. I'm not going to go through this step by step, as I'm sure you're all very aware that when we assess a patient, the wound and the environment, we need to be systematic, and we need to ensure that we look at the local environment of the wound, as well as the local environment that you're practicing in or the patient's even living in. We need to document first and subsequent assessments to guide the appropriate care pathways, as well as to communicate between colleagues and for litigation purposes. When we're looking at the wound, though, we need to focus on the cause of the injury, the anatomical location and duration, take the dimensions. Is there bleeding? Is there a hematoma? If there is, we should be removing the hematoma. Characteristics of the wound bed and the conditions of the flap viability. We need to cleanse that wound with normal saline or water according to protocol. Remove the debris. Please do not clean it like you mean it with aggression or rubbing. In this situation, skin tears are the exception to the rule. But we need to remove the debris. You need to lift up that flap or pedicle, it's often known as, and get it clean, and gently pat the peri-wound dry to avoid further injury. When we look at the tissue, we need to approximate the wound edges. If that flap is viable, we approximate it as best as we can. This is your turn to really try to do your best artwork. Remember, nursing is not only an art, it's also a science. In this case, it's not only a science, it's also an art. Debride any skin flap that's non-viable. When we reapproximate, you can either use your soft finger to reapproximate the skin flap. Forceps, you can, although it can be quite aggressive. Alternatively, you can utilize a cyanoacrylate sponge, 2-octyl cyanoacrylate, or silicone dressing. And silicone dressings work extremely well because you're actually not applying any force onto that skin tear. So you can actually take it where the flap is adhered, place it down there, and then in the direction of the flap, you then align the edges with the silicone dressing. So as Claire mentioned earlier, that we're going to do some questions and answers. So here's your time to practice. Go to the question and answer section, and can you classify the skin tear on your right? So type in, you're in the Q&A section, and tell me, what type is this? Is it type 1, 2, or 3? All you have to do is type in 1, 2, or 3. So get those fingers busy. I can't see anybody answering at the moment. And let's see who gets it right. Type in the Q&A session, type 1, 2, or 3. And you'll see here that this is a type 1 skin tear. There's no flap loss whatsoever. Okay, some of you got it right. Well done. So can you see on the right-hand side, there's no skin loss whatsoever. So the flap can be repositioned to cover the wound bed. You can see it goes right up against the edges and there's no skin lost. So this is a type 1. So please document it. Now, if we have a look at the goals of treatment, there are 6 goals of treatment here. I'm going to go through them extremely quickly. But what I want to show you is that when you pay attention to every one of these goals of treatment, you can see you get really, really good skin healing, okay? And I think this is a really nice progressive stage of all the different stages in healing, from inflammation to proliferation and epithelialization. So yes, moist wound healing is also applicable. This is a wound that was a skin tear that was sutured. A patient, the individual, a trolley went into the back of the individual's leg. Can you feel that pain? And her practitioner sutured it. It's one thing we never do, and that is to suture a skin tear. Why? On frail skin, it will actually cause further damage to the skin. And what will happen here is you can see the consequences are complication. The wound has broken down and become infected. You can see the green tinging of the piacin for pyoderma aeruginosa infection as well. So we really need to identify the adverse effects of exudate. Please remember, when the wound is on the lower limb, to ensure vascular assessment is performed prior to application, something like a simple ABPI. Avoid infection, and it's important to get ready with your fingers on the Q&A only. This is purely just a practice round, okay? This isn't for prizes, so practice. So when I give you the question that is for prize, you know how to answer quickly on that. So the question is here. We have a wound picture on the top and another wound picture on the bottom. The wound on the top is the iatrogenic skin tear, and the wound on the bottom is that paper skin tear that I mentioned, okay, the paper cut. We need to be able to differentiate between inflammation and wound infection. So by typing top or bottom in the question and answer section, which one is infected? The top one or the bottom one? Now, I'll come to the answer just now. You keep typing in those answers. The diagnosis of infection should be based on clinical assessment And we usually use the stages of continuum of infection. You can download these, also freely available, off the International Wound Infection Institute's website, and it also gives you how to manage them. And we need to manage them accordingly. We need to implement appropriate infection control measures and check the tetanus status. So thank you for all your answers. It's wonderful to see your participation, and I really appreciate that. The wound on the top is inflamed. Remember, it's a traumatic injury, so traumatic injuries will have inflammation. The skin tear down the bottom is also a traumatic injury. It is that the patient's left, neglected, unattended, mismanaged, and this has now become infected, has an abscess, and the patient had to spend 2 days in hospital and go in for an incision and drainage of the abscess. So really, I encourage you to go and have a look at the stages of the continuum and how to manage infection and inflammation. Please, pain control is so important. We need to manage pain and select dressings that minimize pain on application as well as on removal. Protect that peri-wound. Mark the dressing with an arrow to indicate the correct direction of the removal, and remove in the direction of the pedicle to promote flap viability. The don'ts of skin tears: don't use sutures and staples due to the fragility of the elderly skin. Don't use adhesive strips unless they are silicone strips, as these can increase the risk of tearing. Don't use gauze. Gauze is for cleaning, it's not for dressing wounds, as it doesn't secure the flap and it increases the risk of flap displacement as well as necrosis. Don't use films and hydrocolloids, as they contribute to MRSA and skin tears. So what do we use? Well, the answer to that is you use the dressing that's appropriate for the patient with a skin tear and skin frailty. And you'll see there's a whole list of different things that we need for the ideal dressing, and Liesl will go into detail here. What I want to stress here, those with skin tears and skin frailty, is you must look at the goal of the patient and what is the aim. And the goal of this patient on the left with a skin tear on his right knee, he had to shower and he had to bath. That was his priority. Didn't matter what dressing I put on, as long as he could do that. Now, if you have a look at the ideal dressing that's put out by ISTAP, waterproof and showerproof is not in there. But for my patient, that is a prerequisite. So I really encourage you, as you can see my arm on the right-hand page, when people come to market dressings, and that's what you require, take that dressing, place it on your arm, put it in the water, and see, is it going to work? Is it going to meet your objective? And fortunately, this dressing did. The other thing is we needed flexibility. Remember, I mentioned one of the criteria is mobility. When we apply a wound over a joint, please make sure that joint is in flexion. And you will see on this dressing, on the windowed area of the dressing, there's creases in that dressing. Now, Essity is probably looking at that picture and going, gosh, Trish, there's creases. How did you show a crease dressing? Okay, it's really important to know that when you apply on a flexed joint and the patient now straightens their leg, you are going to get that creasing, and that assists with the flexibility that is already manufactured into the dressing. And remember, the other thing I want to say is if there are too many creases and your dressing is not adhering to the skin, with a silicone dressing, you can actually lift it and reapply it. So I'd encourage you to go through all of these different criteria. In conclusion, I would like to say that skin tears are traumatic wounds commonly found in the extremes of age, with a healing trajectory commonly for acute wounds 14 to 21 days. We need to recognize risk factors and the causes, and prevention is key in maintaining skin integrity. We need to classify skin tears in order to be able to implement the most appropriate management. We need to maintain the viable skin flap where possible to get as fast healing as possible. And we need to prevent infection, ensure moisture balance, and minimize pain to enhance wound healing and prevent complications. And lastly, but not least, we need to select an ideal dressing to enhance wound healing and minimize the risk of further skin damage, because if you remember, hashtag skin matters and all our skin matters. So here's some recommended reading for you, freely available off these websites, Wounds International and skintear.org. This is the holistic strategies to promote and maintain skin integrity. Liesl will elaborate on that just now, as well as the prevention and management of skin tears in aged skin. So thank you very much for your time and attention. And please do remember, on Thursday, there will be a webinar announced at the end of this webinar as to what you can expect on a World Without Skin Tears Day in 2 days' time. So I'm going to go on to the question, and this you can win a prize for. So the first person to answer in the Q&A section, which of the following strategies will help to prevent skin tears? Using pH-neutral products to cleanse the skin, applying moisturizers twice daily, gentle handling, ensuring good lighting in bedrooms and living areas, or all of the above. Good luck, and I look forward to answering your questions and having a discussion with you later.
Okay, thank you so much, Trish. That was so informative and really practical. Those wounds look so painful and really dangerous if they get infected. So this is such important work that you do. I'm going to hand over to Liesl now and start her presentation for her. Thanks so much, Trish. Here we go.
Hi, everyone. It's such a pleasure to be with you tonight. And Trish, thank you very much for that great presentation. I think it's so important that we get the basics right, and that we understand the skin and how we deal with the skin and how injuries occur. So my task here is literally more about the products and how we use them in practice. So just to quote a very good quote from Kate LeBlanc, if we look at wound care products for fragile skin, remember one thing: when skin tears occur, it is vital that the wound care products chosen will optimize wound healing and not increase the risk of further skin damage. So whichever product you choose, it should not damage the skin. That goes for in theatre, it goes for in your practice, in your private clinic, wherever you are in hospital. So this should include your specialist dressings and the products that you use to clean and moisturize the skin with, which Trish also mentioned. So what is skin frailty? Just to sort of get you guys back again to what was said in the beginning. A risk of threat to the skin, not necessarily a wound, break, or disruption. So always remember, fragile skin can be the neonate, it can be the elderly patient, it can be the paraplegic patient. It's important that we look at each patient as an individual and work with them from there onwards. So who are at risk of skin frailty? Older adults, individuals with mobility issues like paralysis, your quadriplegics and your paraplegics, children, neonates like Trish has mentioned and showed you the photographs as well, spina bifida, cerebral palsy patients, our bariatric patients. Don't think that they don't have skin that are frail. Oncology patients, specifically our patients exposed to radiotherapy, chronic illnesses and other issues as well. So what do we see from this? What's the result that we see? We see skin tears, we see pressure injuries or ulcers, and we also see moisture-associated skin damage, together with skin changes at life's end, which is also known as scale. So we need to prevent all of this. Tonight we focus a lot on skin tears, but by managing the skin correctly, we can actually prevent a lot of other things as well. So this might be a very busy slide for you, and the purpose of the slide is not to go through this in detail, but to introduce you to this best practice recommendation. Trish has also showed you these references. This is a new reference from Beekman et al. In 2020, and you can get it on woundsinternational.com. But it looks at potential factors contributing to the injury, also other elements that makes it worse, like mechanical adhesives, urine, incontinence, all of that. Also, what's the potential injury, like I've mentioned just now, and then what are the potential outcomes of the skin injury? I'm going to specifically look at the potentials and the outcomes, and we'll discuss this a little bit further. Okay, so just to give you a little bit of visualization, what we see, there are many different types of skin tears available. Okay. What you see here on the screen is a variety of the different types, the 3 that Trish has already mentioned. So important, if you look at the top right corner, when there's an area of the flap or the skin tear that is non-viable, that needs to be debrided. It doesn't help you just to leave that on. On the left-hand upper part, you can see also that's a fresh skin tear. Try it, like Tricia showed you, just to align that to the edges, and you will be surprised at how fast that can heal. So what are the potential outcomes of skin injury? What are those complications that we don't want to see happen? Number 1 is pain. If we don't deal with the pain for the patient, it can just get completely out of hand. And then the second one is infection. It depends on how this injury has happened. What you're seeing on the pictures in front of you at the moment are 2 wounds, of the same wound, on different stages. But you can see that it's quite a severe skin injury that was there, and it got infected because of what she bumped against. It can also cause chronic wounds. That's a patient who had a small skin tear but has venous hypertension, and then it develops into a larger wound or a venous leg ulcer. It can cause disability, it can cause disfigurement, but it's also the impaired quality of life if you don't deal with this in a timely manner. Increased cost. If you don't get that skin back and you don't clean it properly and you don't manage it well enough, this can be a very costly endeavor to the patient. It can also have increased length of stay in hospital or even result into sepsis and death. So it's so important that we don't only look at what's in front of us. We need to look holistically, like Trisha's mentioned earlier on, with regards to the whole patient, the underlying comorbidities. What is their situation currently at home? Is there enough lighting? What's going on with the patient? So it's so important. If we want to prevent this in practice, we need to do holistic patient care. And that's where you can use that safety model. Also, again, just repeating what Trisha said, your skin cleansing routine should be so important. Make use of pH balanced products. Don't use that aggressive method that we say, clean it like you mean it. Because if I'm going to rub extensively over frail skin, I am going to cause injuries. And so important, again, moisturize and protect. I specifically want to talk about the leave-on products that we use in prevention and treatment. And this is where your silicone products really comes in handy. If you can protect the skin and prevent further injury, that's where you make the difference. And to me, very, very important when you remove any devices or any dressings. Atraumatic dressing removal means low and slow. So it doesn't mean that you're going to rip off the whole dressing to see how fast you can do it. Keep a low profile, and I'll show and illustrate that to you as well with a little bit later. The ideal dressing for that risk of vulnerable, fragile skin, Trish has mentioned this as well, and we're going to look specifically at the Leukoplast range, how to see how these products fit into this ideal dressing category. So if we look at the Leukoplast skin sensitive range, their benefits, what's being claimed is that it prevents skin stripping and tearing. It's atraumatic removal. It's a skin-friendly silicone adhesive, and it's reliable. So when you place it down, when you secure it, it will stay there. Okay. So the first one in the range is the Leukomed Hyperfix Skin Sensitive. So we can use this to secure dressings. We can also use this to protect the skin in the maturation phase. So here's some of the examples where we've used the product. You need to remove the outer layer, then apply that straight as an adhesive. And there's some examples on the foot, how you do secure it in between the toes. But also when there's scar management, where you would like to make sure that you've got a good cosmetic results, this really works well with scar management for these patients. You also can see how we remove this. This is just an image to show you that even without stretching the dressing or doing a different removal technique, just by gently, low and slow, lifting the Hyperfix, you don't get any skin damage. So it's a very safe dressing. You also get the skin sensitive tape. And this is very similar to what we'd use to stabilize scarring. You can see here's a little girl that had a very bad scar on her arm. And you can see with just a few, this was literally within 2 weeks of treatment, we could see a big difference in the way that the scar responded to the silicone sensitive tape. So this can definitely be used on scarring to prevent that hyperkeloid formation as well. When we look at the skin-sensitive tape, you can also see the other areas where we do use this is post-operatively on the scarring, but also inoperatively on the eye specifically to prevent drying out. When you take this off, there's no damage to the eyelids, and we all know that the eyelids are very sensitive. So if we look at the Leukoplast T and T plus skin sensitive, remember the T is without the island, and the T plus has the island dressing as well there. It has a little bit of added absorption. Very important when you look at these dressings. For me, the main factor is the waterproofness. So if a patient wants to bath or shower, make sure that you get this placed correctly, and you will see that this is one of the dressings that I've personally felt really works well in those. You can see there's an example of a large abdominal wound that we've used it on. It's very skin friendly, very comfortable. There's an anti-shear barrier, so that also works quite a lot. It's flexible and moldable. And like Trish has mentioned with a patient with the knee where she adhered the plaster over there, is that it needs to be flexed, because you need to create that space for when the patient's moving as well. And even if there's a little wrinkle there, because it's silicone, and if you've smoothed it out, this will work very well and it will still be waterproof. It's really easy to apply and remove. Just to give you a little tip, when you do apply it, you see the red strip there. Make sure that you really just rub it nice and gently onto the skin to make sure that that adheres before you take off the second layer. So what you can see here is a demonstration of how we do apply this dressing. So if you apply it very carefully, make sure that on that red area that you tape it down so that you can just lift the top layer. Once this is removed, you can almost not even see the dressing. And that is something that the patients do like, the fact that it's almost invisible. When you want to remove the plaster, again, just break the tension. Even if you don't do that, even if you don't break the tension, these silicone type of plasters really don't do any skin stripping. And that's what you want. And you can see in the last picture, by just pulling it a little bit, you don't even have that there. So for me, if you work with some of our orthopedic surgeons or for some of my colleagues who like to work very fast, this is sort of my backup to say, so when you do rip it off, you're not going to rip off the skin as well. We don't recommend you to do it that way, but I know how we all work in practice. Try to still adhere to low and slow and just protect that skin. So here's also an example of how time-is treatment can treat and manage complications. So if we look at the different wound healing phases, what you would see on the left, that's just post-injury, so the injury phase. The second photograph is where she did develop infection and inflammation of this wound. So you still need to treat that as well. If you treat that correctly, according to any wound healing phase that you're in with the right products, and again, a product that safely won't harm the new skin, you will get through to the proliferation phase and at the end, remodeling or maturation. And you can see this has been a very good cosmetic result. The only scarring that was left was the deep part where there wasn't real good adherence of that skin. So we need to ask ourselves, when you compare any dressing, does it control the bleeding? Is it easy to apply and remove? Is it atraumatic on removal? An anti-shear barrier really works well for us. So it means that there's no added friction for that patient. And is it the best environment for your patient's wounds? It also needs to be flexible and multi-contours. For me, that's essential in a good waterproof dressing. It needs to be flexible. Okay. It also has to be cost effective, because if I want this patient to go onwards with this, it needs to be something that they can afford. It needs to also extend the wearing time. If a dressing sticks better, it can last for longer. It needs to optimize the quality of life. An ugly plaster is a plaster that's not going to last. So it needs to at least have that life and cosmesis as well. Provide secure but not aggressive retention. So when I place it in where I want it to be, it will stay there, and it needs to be non-toxic. So very important for us is these hashtags. This is all part of the campaign, Save Our Skin and Skin Matters. You can make a difference. And you can make a difference by choosing products that would protect the skin and not harm the skin. And I do hope that this has provided you with some information as what you can use as well. I work at Eloquent Health and Wellness in Pretoria, and we do deal with a lot of different wounds. And you're welcome. If there's any questions, you can even contact me if you would like to do that. Our next slide will be all about, unfortunately, the questions won't be on my slide, but we will get Claire to actually ask you the questions for the competition as well. And please remember that you need to choose the right ones. or just one, and do that in the Q&A only on the right corner of your screen, not in the chat room. Otherwise, you're not going to get those beautiful prizes. And there are 3 absolutely amazing prizes. Am I right, Claire? Claire, your sound's not on.
Right, that's absolutely correct, Liesl. Thank you for really important messages that you've brought across in your presentation. I'm going to display your question shortly. Okay. Sorry, just bear with me.
No, that's fine. While Claire's just busy getting up the question, I think it's so important that you also realize that when you choose your dressing, usually why a silicone dressing does not stick is because you did not dry the skin properly before you put the plaster down. So very important that you need to make sure that the surrounding skin is dry so that there's no moisture trapped within the silicone itself. So very, very important when you apply any silicone dressing, make sure that the skin surrounding is dry enough for you to put your question on. So my question is, what is the adhesive made of within the Leukoplast skin sensitive range? A, is it acrylic? B, latex? C, silicone? Or D, hydrocellular? So hopefully you've listened to the whole presentation, and I see there's some real fast answers here. I hope we have good winners. Thank you so much, Claire.
Thanks for bearing with me there, and thank you to everyone who's answered the question. It must be in the Q&A only box, by the way, and it'll be the first person who answered correctly. Please let us know if you have any questions. Do remember there is a prize for someone who asks the best question or the most interesting question. It is a really important topic that we are dealing with tonight, skin tears and fragile skin, and it really is life-changing for these patients who have to deal with it. So once you've posted your answers to the various questions, please do feel free to ask away. We have the experts here, so make use of them while you have them.
Well, Trish, I think you've seen there's one question from Pinky there, where she asked, with the waterproof dressing I've used in the past, I often find maceration under the dressing. I suspect it's due to film, not breathable. What is the best way to prevent that?
Okay, thanks for the lovely question, Pinky. Maceration, peri-wound maceration is one of my biggest pet topics. We need to really protect the peri-wound. We need to peruse it, protect it, and prevent it from actually breaking down. So the first thing is to see, are you choosing the adequate dressing, the best dressing for this wound? So if you're getting maceration, number one, have you selected the correct dressing? Is it absorbent enough for the viscosity of the exudate? Because perhaps if you've just chosen maybe a film dressing for something that is highly exuding, it would not be absorbent enough. So that's what I would look at first. Secondly, if you have, we need to know how to choose dressings, low to moderate with your film dressings and your hydrocolloids, please not with skin tears. And then you would step up with foam dressings, go up to your super absorbents, and eventually your negative pressure wound therapies if necessary. Hopefully your skin tears never complicate that badly that you need to use that technology. And the other thing is to use a skin protector. So you could use cyanoacrylate, skin barrier protective wipes, there's skin barrier protective sprays, some 2-octals or even the ordinary polymer cyanoacrylates, and the swabs. And then choosing the correct dressing. As I've mentioned before, with your maceration, is it the correct sized dressing? So you should always have at least 2 centimeters extra of your dressing that actually goes over the wound. And some publications even say 4 centimeters beyond the wound edge to ensure that you are absorbing the exudate. And my last point here is, when you are selecting a dressing, you need to know the moisture vaporization transpiration rate, the MVTR. And this is not an advertising marketing concept. Our skin has a natural MVTR to it, and therefore the dressing also needs to have an MVTR. What does that mean? That it can breathe, it allows for gaseous exchange. Microorganisms cannot penetrate the dressing, but the gaseous exchange can occur. If it has a very low MVTR rate, you will also get maceration. So long answer to a short question. Pinky, I hope that's answered your question.
Thank you so much. There are some more questions. Someone says, I just want to find out, lots of patients get blisters due to the glue used in dressings. What type of ingredients are used in the glue in Leukoplast skin sensitive range in order to prevent blisters and skin tears?
I think if you've answered C correctly in my question, you will know by now that it's silicone. So it's a pure silicone, and that's the reason why this works so well. When you do see blisters, and that's from my experience in my practice specifically when I do get patients like that, it's often not only because of the glue in the plaster, what you would like to say like that, it's what has happened before that. How was the skin positions? Was there tension on the skin when you applied the dressing? Because all of that can cause blisters as well. It's not only the adhesive that causes that, it's the technique of how you do apply your dressings as well. Some of the dressings will have harsher glue than others. It depends on what's the make. But if you look at what's generally out there in the market that we are focusing on now, are dressings that has a skin-friendly adhesive to that won't cause that. And that also means that these dressings can stay on for much longer. You can keep them for 7 days or even longer. If there are no problem with the dressing, there's no leakage, you can even leave it on for longer for these patients. Tish, any comments from your sides on that?
Well, I just want to say, not just because it's a sponsored webinar whatsoever, but from an academic point of view, is that silicone has really revolutionized wound management from a skin frailty point of view.
Okay, great. Does temperature play a role? Someone asked, in the summer months, do the summer months have any negative impact when using silicone dressings?
If you don't dry the surrounding skin, yes. Because if you don't make sure, especially if it's a patient sweating a lot and you struggle with that in your obese patients, for instance, as well. If you don't take care of your skin hygiene around the wound, there's no way that you're going to get any dressing to stick the way that you would like it. So we do again say, it's again the technique of how do you clean the skin, not only the wound, which has an impact on that. And also, again, when you choose your silicone dressing, irrespective of what type of dressing you're using, if it's a foam, silicone, or whatever, is that the dressing is the correct size for the wound, that there's enough space in the dressing that can absorb so that you don't have that problem with the patient.
Okay, you're in agreement with that, Trish? Anything to add?
Yep, no, I agree.
Okay, is the melalin dressing okay to use, in brackets, shiny side to wound? Is the melalin dressing okay to use, shiny side to wound?
Any dressing is okay to use on a wound, depending on what you want to achieve with the dressing. The shiny side that you're talking about is actually the talfa that prevents that from sticking to the wound bed, which is a different dressing as to what we are currently talking about in this webinar. So again, here, important to understand when you get a dressing from any manufacturers that you understand what the dressing is made of and how it should be applied. That's the first thing.
Okay. Well,
I'd like to just add a comment there, maybe, if you don't mind. I think that's Jean Goldstein or Jean Goldstein. I think it's important, if you would like to, Madam Mr. Goldstein, is go and have a look at the ISTAP website, download that best practice of skin tears. There's a whole section on recommended dressings. It has been updated, and you'll be able to see the selection of the dressings and the dressing that you are requesting, and it'll all be stated there whether you can or can't use it. It has been updated slightly. One of them is do not use iodines. You can use iodines as long as they're in certain formats, but you'll also see that there's an adjustment to that there on that best practice document. So it's quite comprehensive.
Okay, so you kind of answered the question about iodine as well there.
No, I think the question there is quite different. It says, will iodine disinfectant affect the silicone dressing?
Yes.
Yes, I think it's quite different. Do you want me to answer that, Liesel? You okay? Okay, so
The bottom.
iodine disinfectant, number one, are you using the disinfectant because the wound is infected? So that's the first thing I'm going to ask. And perhaps you could maybe go and have a look at the International Wound Infection Institute's new consensus document. It was published in March this year. So it's free of charge. Go and have a look at that, Andrew, about disinfectants. Does it affect silicone dressings? It won't affect it except if you do not ensure that it's dry before the application of the silicone, as Liesel said. But will it of the dressing or the MVTR? I don't know about the MVTR. Studies of that. We'd have to use, and I'm sure. And the other thing is no moisturizing. Okay, so I kept enhancing moisturizing for skin tears to prevent skin tears. Please do not apply a moisturizer on the peri wound if you are using a silicone dressing, because then it won't stick. So even your iodine gels and ointments, be careful that you don't we shouldn't be using certain of them. I won't discuss product names this evening, but we need to look carefully there. But yes, make sure that you don't use so much gel or ointment or cream that as you apply the dressing, it literally presses the ointment onto the border aspect or the window aspect, because it won't adhere. I hope I've answered
and that happens quite often in practice. Trish, I think that's an absolutely good remark, because often enough when we do apply creams or dressing ointments and stuff like that, we tend to apply too much, and once you put down your dressing, it actually comes from the middle of the dressing out to the sides of the dressings, which lead to the non-adherence of the dressing.
Thank you so much. Someone has asked, are they colophony free?
Okay, so for those of us that don't know what colophony is, Marinda wasn't aware of what colophony is. I had to go and have a look up for your question. It does say it's a tackifier resin for hot melt adhesives for high pressure sensitive road marking print ink. So I'm not sure about that. I'm going to say I don't think so. I've never heard of that in the dressing. I do know that Liesel's doing the product aspect. Liesel, are you aware that if there's any colophony resin in it? Or
not that I'm aware
resin?
Of. Not that I'm aware
as far as I'm aware
of.
Yeah, it's a silicone layer with an absorbent layer. So your silicone is attached to the skin, and then you have your absorbent layer with your transparent film on the top.
But I'm sure if you contact your representative in your area and maybe ask them that question as well, they can answer that, because they're the product specialist. With us, we would like to know exactly how it works. One thing I always do when I work with any silicone dressing, if you want to test if it's a pure silicone, is very, very easily. Once you've taken that dressing from its backing, there should be no residue on the backing of the dressing. Because if there's any residue stuck on the dressing, then there has to be something added to the silicone. A pure silicone literally just slides off your dressing that's on the adhesive part. It's one of the ways that we always tend to look at, see how is the silicone good and staying intact. Because if any dressing residue stays behind on the film backing or your contact layer before you apply to the skin, it means that there can be some residue also staying behind on the patient's skin. And that's what we don't want. So in the case of this product line, there's no residue staying behind on the skin. There's nothing left behind. If you've looked closely at the pictures, and once you can actually revisit these slides, you can go and look in closer of that. There's nothing left behind in the skin. No skin stripping, no residue, nothing. And that's what you would like in a good silicone that protects the skin. That's what you should aim for with your dressings.
Okay, great. Miranda's asked, do silicone dressings have a role in scar management?
I had a slide on that. Yeah, I actually showed you a slide where we did use some of one of the products specifically, the sensitive tape in there. Silicone products play a huge role in scar management. If you even look at your burns patients, we with the OTs together, we make these silicone garments for them to help with the scarring and prevent further, or try to prevent keloid formation for these patients, that you can compress the scar. So silicone, in a sense, when you use a silicone dressing, you already are doing some scar treatment for your patient. So it definitely is a product that there's a lot of them available, but you can certainly use them in scar management. If you remember correctly, I've had two photographs, or not two slides. One was post-operatively on several suture lines, and then the one was the little girl with the keloid where we used it specifically.
Fantastic. I've received this as a private question. Do you have a separate section on wounds in diabetic patients? I don't know if you want to address that at all, diabetic wounds.
I'll address that. I think this evening our focus is on skin tears. And yes, diabetics also get skin tears, and they're high risk too. But the same principles will apply as what we've discussed today. But you therefore also need to look at, from any wound management point of view, the holistic approach to the diabetic. You know, what's his HbA1c? Is he controlled? What's his diet? Have you referred him, etc.? And look at the whole holistic approach. And treat it as any other diabetic wound. When I say that, from an assessment, history taking, and management part of the comorbidity. But the skin tear you would still treat and manage in the same way that we've discussed this evening.
I think what's important there, what we can maybe also add with when you're looking at the diabetic foot, one of the photographs that I showed of a skin tear in that example slide was actually a diabetic who put a wrong plaster on and literally ripped a piece of skin off the plantar aspect of the foot. Because a diabetic can't feel due to neuropathy, they are prone to use harsher plasters or dressings. So you also need to educate your patient about that and make sure that when they use anything, that it is a skin-friendly adhesive.
Okay, another question about scar management. Would it help 12 months after the scar has been formed, i.e. radical mastectomy or breast reconstruction?
The little girl that you saw was actually a few years after that scar, and we still had a good result. So from experience, I'm working with a plastic surgeon as well. Sometimes you need to do a scar revision if a scar is really that bad, but we always try to go first the conservative route to see with silicone products what you can achieve. It's also all about stabilization and moisturization of the scarring, but that depends on the severity of the scar. So it worked well for this one case that I've used it on. That scar is much lighter, and that was a scar that was, like I said, a few years old.
That's fantastic. Okay, I don't see any more questions at the moment. I would really just like to thank so much our presenters for your really hard work that's gone into these presentations and sharing your knowledge on this really important topic. And to you, our audience, for your participation. And lastly, to SCT Leukoplast for making this webinar possible tonight. As was mentioned earlier, their next upcoming event is a World Without Skin Tears Day in 2022. You can find more information and register for free. I am going to put those details in the chat section for you, so you can see the web address there if you would like to register for that. And yes, thank you, Skinsen. Yeah, some great comments from people, and people are amazed that there's skin-sensitive tape and very informative. So I can announce the prizes. Please just give me 2 seconds to get the correct screen.
We are not getting any prizes at the moment because they are really good.
Exactly. Okay, here we go. So these are the prizes that are up for grabs. So the first prize goes to Anne Maxwell, who was correct in answering Trisha's question, which was E, all of the above. The next prize, which is the fast wireless charger, goes to Engela Lutz for giving option C. These are all in the Q&A only boxes, the first ones that came up, so well done. And the bamboo phone stand goes to Zashni Harilal for a really great question. I am going to put my email address in the chat box, and if you can just contact me, we will get your prizes to you. So I'm going to put in the chat.
Well, congratulations to all the prize winners. I'm really jealous. Don't know how jealous she is. Who doesn't want to comply? Tell us about that at the moment. So
I'm very jealous.
No, I am.
And
too.
I'm very impressed with the audience interactive and all your answering of your questions. Well done. It's so good to see healthcare professionals do so. And it doesn't matter if you get an answer right or wrong. To be honest, every answer is a learning curve. And I think that's what's important about answering questions. From our mistakes. And we know what we do know, and we go and research what we don't know. So thank you so much for your interaction and participation and time this evening. And well done to those excellent prize winners, lucky prize winners. I'm jealous.
Yeah. Now, thank you very much, everyone, for your questions. It's always great to see people interacting. As a presenter, you sometimes feel very alone on this side of a computer. And this was actually a very enjoyable session. So thank you for making it worth our while, and also your while. And hopefully you would have learned something today and really make it practical for you in your practices. Because if we don't take what we've learned from a webinar like this and we apply this, we don't go forward. And I think that's what's important in life. If we want to change and make a difference, go and apply what you've learned and go and test it out for yourself. I mean, don't take my word that the products are great or whatever. I always say go test it for yourself. Go do like Trish has done. Put your arm into the water and see if it's leaking or not. That's how we do, and it's how we learn. So thank you very much, everyone, for your questions and your answers. Claire, thank you for hosting us. Trish, as always, it's been a pleasure just to host with you. Love it to bits.
Thanks, Liesl. Thanks, Claire.
Thank you so much to everyone. Well done to everyone who participated, and especially those who got the questions correct. As mentioned, it was Anne Maxwell, Engela Lutz, and Zashni Harilal. I've put my email address there. It's claire.rush@newmedia.co.za. Please email me, and the good people of SAT Leukoplast will make sure that you get your prizes. So well done, everyone, and thanks again for joining tonight. Have a safe and happy long weekend if you are traveling, and thanks again. Take care, everyone. Good night.
Bye.
Bye.